Hello, welcome to part 3 of this series of video lectures on drugs acting on the respiratory system. Specifically, we're talking about the treatment of asthma and COPD. And so, in the second slide set, we talked about the bronchodilators. Now we will proceed to focusing on the quote-unquote anti-inflammatory agents. However, before that, we'll have a short quiz. And so please get a piece of paper and write down your answers to each of the questions. So the first is, which of these drug classes is preferred as bronchodilator? Is it A, the beta agonist, B, the catecholamines, C, the muscarinic anticholinergics, or D, the methylxanthines? Next, what is the specific drug of choice as relievers? Is it A, SAMA, B, theophylline, C, SABA, and D, aminophylline? Third question, which of the following is the prototype SAMA? Is it theophylline, B, ipratropium, C, tiotropium, and D, omeclizidinium? Number 4, true or false? LABAs or LAMAs are the preferred controllers for COPD. So although we haven't really talked about this at length, it was somewhat discussed in the last video lecture. And finally, true or false? LABAs can safely be given as the controllers of choice in asthma. And so here are the answers. The first is A. Beta 2 agonists are the drugs of choice as bronchodilators over the methylxanthines, over the catecholamines, or even the muscarinic antagonists. And what are the specific drugs of choice as relievers? Of course, there's SABAs. The prototype SABA is salbutamol. And so for number 3, the question is the prototype SAMA, and that's B, ipratropium. And then we had 2 true or false questions. The first one is the question of whether LAMA or LABA, the long-acting bronchodilators, are preferred as controllers in COPD. And that's true, no? And that is different with asthma, because in asthma, the preferred controller are the inhaled glucocorticoids or inhaled glucocorticoids combined with LABA or LAMA. And then the last question is that whether LABA is good enough for controller in asthma. No, the answer is false, because the LABA should always be given with the ICS in asthma. We never do monotherapy of bronchodilators, long-acting bronchodilators in asthma. Although this is true in COPD, where you can give LAMA or LABA, in asthma, the drug of choice as controllers, as I've said, is ICS. And if ever you will use bronchodilators, they should always be combined with inhaled glucocorticoids. So that's our focus today, a talk on the different controllers for asthma. And so we will briefly talk about the glucocorticoids again, both the systemic and the inhaled glucocorticoids, of which there are 3 types in the Philippines in terms of respiratory inhaled therapy, and that's beclomethasone, budesonide, and fluticasone. So although in literature there are many listed, in the Philippines, actually the 2 major are just budesonide and fluticasone, but sometimes you do have beclomethasone. The second controllers would be the leukotriene receptor antagonists. So these are competitive inhibitors for the receptor of the leukotrienes, and foremost of this is montelukast. The next are the leukotriene synthesis inhibitors. These are actually not available in clinical practice. These are really more in the research realm. And then we have inhibitors of mediator release, no? Especially the chromones. And then some other drugs that are important in allergic or atopic asthma, the sublingual immunotherapy or SLIT, And the antibodies, the biologics, anti-IgE, anti-interleukin 5, anti-interleukin 5 receptor, and anti-IL-4 and anti-IL-13. And so we begin with the glucocorticoids, which you've actually taken up in a previous module. You remember that glucocorticoids exert their main pharmacologic action as inflammatory agents by inhibiting the arachidonic acid release by phospholipase A2. So remember again that all cell membranes contain a phospholipid bilayer. And with injury or any irritant, no, then arachidonic acid is released by the enzyme phospholipase A2. Glucocorticoids also inhibit the functions of different cell elements, including eosinophil chemotaxis. And although they do not directly relax the airway, smooth muscle, and they have very little effect on acute bronchoconstriction, glucocorticoids are important in decreasing the swelling and the exudation that happens in asthma. You have seen this graphic in the previous lectures of glucocorticoids, and glucocorticoids act on this main pathway. They inhibit the action of phospholipase A2 enzyme so that the arachidonic acid is not released, and this is mainly by the induction of formation of lipocortin. Glucocorticoids also inhibit the induction of the cyclooxygenase enzyme, which then inhibits the formation of the prostaglandins and the prostacyclins. And here you can see that therefore glucocorticoids inhibit the mediators of asthma at this level. And so by inhibiting the formation of the arachidonic acid, you actually inhibit also the formation of your leukotrienes. Now, with regards to asthma in particular, glucocorticoids can reverse the mucosal edema, they decrease the capillary leak, and like I've said, they inhibit the release of the mediator leukotrienes. They decrease the number and activity of cells involved in airway inflammation, and with prolonged use, and this is very important, they reduce the airway hyperresponsiveness to a variety of different bronchoconstrictor stimuli. And that's why typically when we give inhaled glucocorticoids, it's given for at least 6 months. Now, again, you've seen this, the molecular mechanism of action of steroids. So the glucocorticoid is able to freely pass through the cell membrane where it encounters its cytoplasmic receptor, which then bind to the glucocorticoid response elements in the promoter regions of genes, preventing the synthesis of the inflammatory proteins. However, if transcription factors such as nuclear factor kappa B and activator protein 1 have already been activated by cytokines, then the glucocorticoids may actually also directly bind to them, preventing their interaction with the inflammatory genes. This is again shown graphically in this slide, no? The glucocorticoids, after it encounters its receptor in the cytoplasm, the receptor lets go the heat shock or protein 90, which are the chaperone proteins, and there is then translocation of the GR glucocorticoid complex after dimerization, and then translocation into the nucleus where it intercalates the DNA. And there are two major effects. The first is the transcription, no, of certain important proteins, foremost of which is lipocortin, and you have already seen that lipocortin directly inhibits the action of phospholipase A2 so that the arachidonic acid is not released and you do not proceed through the entire arachidonic acid pathway. It also again inhibits the formation of inflammatory proteins such as cytokines, the induced nitric oxide synthase, and even the induced COX-2, all of which are important in decreasing the inflammatory processes in asthma and in other inflammatory conditions. Now, when we give steroids, please remember that as much as possible, we would like to give topical steroid. And so that's why the mainstay or the drug of choice really as controller in asthma are the ICS or the inhaled glucocorticoids. They're the mainstay in prophylaxis as controllers and as chronic treatment. They directly target the site of action, which is the lungs, the airways. But unfortunately, it takes a while before you are able to achieve the optimal therapeutic effect of the glucocorticoids when given as inhalational drugs. So for some patients who are having acute exacerbations of asthma, especially if they're severe enough to require physician visits or hospital emergency room visits, then they should be given systemic glucocorticoids. And the typical drug of choice is prednisone because it is more potent, but with half the mineralocorticoid activity of the hydrocortisone. No? And this short-term use, typically in 5, even a maximum of 7 days. And while you're already taking the systemic steroids, you have already started the inhaled corticosteroid therapy, so that within 5 or more days, and you then discontinue the systemic steroids, the effects of the inhaled glucocorticoids would already have been optimal, no, or near optimal. Now, how much steroids, especially inhaled glucocorticoids, will be needed? So that will be answered later on in your discussions of how to use the inhaled glucocorticoid therapy. It is not intended for you to memorize tables such as this, but just to tell you that we are able to differentiate between what is low dose, medium dose, and high dose inhaled glucocorticoids according to the dose. And this comes into play when we are managing asthma, because what we give in terms of the potency of steroids will depend on where they are in our rubric. It depends on how severe the asthma is. No? So for example, if they're just on step 1 or level 1 of asthma, maybe they will just be given low dose therapy. And for those who are in higher stages, let's say level 4 or step 4, maybe they will be on the high dose glucocorticoids. So please never memorize these tables. Most of the adverse drug reactions of the glucocorticoids, as you know already, are due to long-term systemic use. And therefore, when you use these drugs as inhaled therapy, the only anticipated major adverse drug reaction is actually oropharyngeal candidiasis due to the direct deposition of the glucocorticoids in the oropharynx. And so the most important instruction for the ICS is to tell your patients to gargle after every use. Now, once again, I've already somewhat told you about it. When do you decide to give inhaled? When do you decide to give systemic therapy? So whenever a patient is coming for acute exacerbation asthmatic attacks, whether in the in or the outpatient, we typically should put them on systemic steroids. And the advantage is the quick action and you are able to reach steady state very quickly. The disadvantage, though, is because of the systemic administration is the greater probability of adverse drug reaction, especially when given at high doses and for prolonged periods of time, typically more than a week or more than 10 days. Now, the inhaled glucocorticoids, the advantage, of course, is the minimal adverse drug reaction. The drug is delivered to the site where the action is most needed. However, the onset of action is delayed. No? So if the patient comes to you in the outpatient with very minimal symptoms, early morning awakenings, but is not in an acute attack, yes, you can put them on inhaled glucocorticoids. But if you see them in the OPD or in the ER and they are having an acute asthmatic attack, typically we will give systemic steroids for maybe 5 days together with the inhaled glucocorticoids because of the delayed onset of effects of the inhaled glucocorticoids. And again, the preferred drugs would be prednisone or methylprednisolone. So if you review the previous lecture on glucocorticoids, remember that methylprednisolone has a slight advantage to prednisone because of the methylation of the basic structure of prednisolone. This allows for better penetration into the lungs, theoretically. However, it is more expensive, so much more expensive than prednisone. And so typically the preferred systemic glucocorticoid in acute asthmatic attack is prednisone. For adults, what is considered to be high dose and the dose that can be given is for acute attacks is 0.5 to 1 milligram per kilogram per day in 2 divided doses. And in children, double that, 1 to 2 mkd. Now, in terms of intravenous glucocorticoids, this may also be given if the patient in the emergency room is unable to swallow because of the difficulty of breathing, the dyspnea. Then you can also give intravenous hydrocortisone. But for long-term use as controller, it is really the inhaled corticosteroids that are preferred. So we've talked about the use of steroids in asthma. How about in COPD? Are they effective? And looking at the main outcome of FEV1 and looking at whether this is improved along with symptoms such as exacerbation with oral steroids use, what they have seen is that there is little benefit actually in giving inhaled or oral glucocorticoids in preventing subsequent decline in pulmonary function. And for this, only smoking cessation actually works to prevent the progression of COPD. But in more severe COPD, and you will realize this soon when you talk about the rubric in COPD, in step 4, there may be a role among these patients who have frequent exacerbations, as the use of inhaled glucocorticoids may prevent further exacerbations. Now, we've talked about the fact that it is the inhaled glucocorticoids which are the preferred drugs as maintenance or controller therapy in asthma. But if you take a look at the pharmacokinetics of inhaled glucocorticoids, we realize that you need to be able to use the inhaler correctly in order that a significant proportion of the dose would be deposited in the lungs. Here, if you do not use a spacer, and you actuate the inhaler, a good proportion of what you actually actuated may just be deposited actually in your oropharynx, and this may be swallowed. And therefore, if you use a spacer and this allows the drug to be inhaled better, then that will improve actually the percentage amount of the ICS dose that is deposited in the lungs. Now, the swallowed dose would of course go through the gastrointestinal tract and will be inactivated to the first pass metabolism of the liver, so that a very small proportion will find its way in the systemic circulation. And potentially, if you are using high dose glucocorticoids, may still exert some systemic side effects. Again, these are the three main kinds of glucocorticoids, inhaled corticosteroids, that are available in the Philippines, mainly actually budesonide, fluticasone, as well as peclomethasone. So we've already talked about the glucocorticoids, and suffice it to say that I have tried to emphasize that inhaled corticosteroids are the drug of choice as controllers or preventers in asthma. In COPD, it doesn't have much role, and its role only is in severe COPD. In the rubric, this is step 4, when there are frequent exacerbations. I will also point out later that there are other guidance, no, as to when to decide to put patients with COPD on inhaled glucocorticoids. That will be in the fourth and last lecture. So moving on, we've talked about the glucocorticoids, both systemic as well as inhaled. We move to the next controller, and these are the leukotriene pathway modifiers, of which there are two kinds, the LTRA, or the leukotriene receptor antagonist, and the prototype drug is montelukast. The mechanism of action of these orally available drugs, both as tablets and syrup in children, is that they are selective, high affinity, competitive antagonists of the cysteine leukotriene 1 receptor. So they compete with the leukotrienes for their receptors. On the other hand, in development are also leukotriene synthesis inhibitors, and the prototype here is Zileuton, and they inhibit the formation of all 5 lipooxygenase products. However, this is still in research and drug development and is not currently available for clinical use. So again, just to show you the where leukotrienes fall at, no, in the pathogenesis of asthma. So you can see once again with the stimulus, let's say the trigger or the inducer, there's a disturbance of the phospholipid bilayer in the lungs, in the airway, and this would lead to the action of phospholipase A2, releasing the arachidonic acid, and then further enzymes, lipooxygenase and cyclooxygenase. So the lipooxygenase enzyme will then result to the formation of the leukotrienes. And the most important leukotrienes that have clinical relevance in asthma are leukotriene C, D, and E4, which are important in causing bronchospasm, congestion, and mucus plugging in asthma. As well, the action of the cyclooxygenase enzyme that I've showed you in the previous slide is also inhibited by glucocorticoids. Also has a contribution in altering the vascular permeability, the bronchial constriction, because of the prevention of the formation of prostaglandins and prostacyclins, as well as the thromboxanes. So really, the leukotrienes are a very important mediators, and therefore counteracting their action by competing with the receptor is a very important way to address the pathogenesis of asthma. Now, I've already said this regarding the mechanism of action of the LTRAs, or in general, the leukotriene pathway modifiers. In the past, they were thought to be adjunctive medicines, especially in children. But now we have been able to see that they're very effective as controllers. And due to their availability in tablet form as well as in flavored chewable tablets and syrups, they have been used as maintenance treatment for children with bronchial asthma with actually quite good outcomes. The only problem with the LTRA, or the leukotriene receptor antagonist, or montelukast, is now there is a black box warning, because they have recently recognized that prolonged intake of montelukast could actually cause some form of psychological or psychiatric problem, and it has been reported that depression has been precipitated among people who were predisposed. And so this is something that we consider in terms of prescribing. So this figure just outlines for us the importance of really counteracting the effects of the leukotriene C, D, and E4 in terms of decreasing the plasma exudation, mucus secretion, the eosinophil recruitment, and even bronchoconstriction. So we're done with glucocorticoids. We're done with the leukotriene receptor antagonist, mainly that's montelukast. And so we move on and talk about other controllers. And in the next few slides, when I talk about controllers, these are mostly actually controllers for those who have atopic asthma or asthma that has a very strong allergic component. And so the first and probably the oldest drug class are the chromones. And these chromones inhibit mediator release from the bronchial mast cells. They may be able to reverse leukocyte activation and trafficking in the asthmatic airways, suppressing the activating effects of chemotactic peptides on neutrophils, eosinophils, and monocytes. And finally, as well, inhibit the parasympathetics, the vagally mediated bronchoconstriction, and even the cough reflexes. The prototype drugs among the chromones are cromolyn sodium and lidocapromil. They're effective prophylactic anti-inflammatory agents, but of course, they're not really that much used as relievers. They're available in inhalational dry powder form, and the only other drug that was available in the market is called ketotifen. Cromolyn sodium is not only useful in allergic asthma, it's also useful in allergic rhinitis. And although I have enumerated actually many mechanisms of action, the actual cellular or molecular mechanism of action is not as well known. And it is theorized that the administration of cromolyn sodium alters the function of the delayed chloride channels in the cell membrane, which inhibit the cellular activation of the various blood cells that are involved in the allergic reaction, inhibiting the liberation of the mediators of allergy that are released by the degranulation of mast cells after the antibody-antigen interaction. And so we're done with the third controller. We now go into the fourth controller, the sublingual immunotherapy or the slit therapy, which has significant advent in the treatment of asthma. And it has only been in the last 3 years that the use of the slits have been incorporated into the management of asthma, both among adults and adolescents. And if you will read the fine print, it actually says where there is a symbol here that at step 4, when asthma severity is increasing, that you can use high-dose inhaled glucocorticoids or the LAMA tiotropium or add on LTRA, and then there's a symbol there that says that you can consider also slit therapy for sensitized patients with allergic rhinitis and an FEV1 that is greater than 70% of predicted. So I think that's shown in a much bigger text here. And this only started in the GINA 2017 and has been carried to the newest Global Initiative Against Asthma 2020 guidelines, where the slit therapy can be considered in adult patients and those adolescents 12 years old and above with allergic rhinitis who continue to have exacerbations despite inhaled glucocorticoid therapy, provided that their FEV1 is still quite high. Now, in the US, their approved slit is made of, what's available are 3 different allergy tablets that are put sublingually. 2 are directed at different kinds of grass pollen, and 1 is for short ragweed, which are the types of different weed allergens that are found in the US. So enumerated here are the different agents that are manufactured by 3 different drug companies. And so what do you think? Will this work for us? Typically not, because we have different allergens in the Philippines. And if you must know, and I'm not sure if your professors in allergy and immunology told you this, they actually are trying to develop our own treatments. And they're doing that by first taking a look at what are the common allergens and then trying to later on develop also our own kind of therapy, much like what they have in the US. And so this does not have any much role in our setting because the types of grass or weed or allergens that they have put in this sublingual immunotherapy do not really apply to us. So moving on, and again, these are drugs that are important for therapy, mostly of allergic asthma. We now are at the point that we are using biologics for allergic asthma. And biologics are really diagnostic, preventive, or therapeutic products that are derived or obtained from living organisms. So in this case, these are antibodies, no, that are directed against the IgE, against the interleukin 5 or its receptor, and also against interleukin 4 and 13. And I know that you just had your lecture in immunology of asthma, but just to point out to you that after the antigen presenting cell that has interacted with the allergen interacts with the helper T cell, then what happens is a cascade of events where the end point is that the B cell will be able to produce IgE. And this IgE, when it binds to the mast cell, will, as you know, trigger mast cell degranulation and a cascade of events that then would lead to worsening of allergic asthma. And so after you've given inhaled glucocorticoids, LABA or LAMA, and the patient fails to respond to all of your interventions, that's a time that you think about the biologics. And the specific targets are pointed out here. You can have antibodies directed against the IgE. You can have antibodies directed against interleukin 13, interleukin 4, even interleukin 5, and the receptor of interleukin 5, as well as many other targets. But what has worked best so far is actually the IgE-specific antibodies. And so if you take a look at this IgE monoclonal antibodies, again, like I've said, they're an option for the treatment of severe persistent allergic asthma as add-on therapy only in adults, and actually it's labeled as adolescents, no? But in fact, even 6 years and older may be given for severe persistent allergic asthma. The specific drug that is available is omalizumab, and it's given as a subcutaneous dose every 2 to 4 weeks. So please don't, you no need to memorize the dose. I'm just showing this to you to tell you how it's given. And it can be given for at least 12 weeks. This anti-IgE is recombinant humanized monoclonal antibodies that recognizes IgE at the same site as the high affinity receptor for IgE. So instead of the IgE binding to its receptor, it will be bound by this recombinant antibodies, and so it will not interact with its receptor, and therefore it will not trigger mast cell degranulation, as shown here. So here you can see that the omalizumab, or the anti-IgE antibody, will bind to free IgE, decreasing the number of cell-bound IgE. And this can therefore lead to a decrease in mediator release by the mast cell or the basophil. And this therefore decreases the allergic inflammation, preventing exacerbation of asthma and reducing symptoms. So this is taken from Nature Reviews. However, being an antibody, it will have some adverse drug reaction, foremost of which is anaphylaxis, but thankfully it's not very common, but it is strongly associated with the drug. In a small percent also of those given the drug, they could develop malignant neoplasm. But by far, the more common ADRs will be injection site reactions and upper respiratory tract infections. Now, there are also antibodies that target the T helper 2 response, no? And again, these are used for asthma and atopic dermatitis. So we have anti-IL-5, anti-IL-4, and the anti-IL-4 antibody is actually directed against the interleukin-4 receptor subunit. So these are some of the available approaches. And if you take a look at the guidelines once again, what is currently being advocated are the antibodies against IgE, against interleukin-5, interleukin-4 receptor, and interleukin-13. And just to show you one of these, interleukin-5 antibody, mepolizumab, no? This has a similar adverse drug reaction as the omalizumab, in that it can cause also some injection site reactions. No, it can also cause some upper respiratory tract infections. And again, it is given for severe eosinophilic or allergic asthma. The blockage of the receptor, the drug that is given for that is benralizumab. So I'm just telling you what are the commonly available drugs, no? Aside from the anti-IgE. And again, the adverse drug reactions, very similar: respiratory tract infections, upper tract infections, and injection site reactions. So far, we've talked about the different controllers. I talked about the glucocorticoids, and then we talked about the leukotriene receptor antagonists, focusing mainly on montelukast. And then we talked about the hormones, and then we moved on to the slit therapy, no? Sublingual immunotherapy, and then finally the biologics, the antibodies. And so far, from the first video lecture all the way down here, we've been able to talk about the different reliever medications, the BAM, no? The short-acting beta agonists, the SABA, the SAMA, the short-acting methylxanthines. And we also said that if you give systemic glucocorticoids for around 5 days at high dose, then this would be very useful for severe in asthma exacerbations. And some still use oral short-acting beta agonists, but again, because of the adverse drug reactions, these are not in use. So again, what are the reliever medications? The reliever medications are typically the bronchodilators BAM, beta-2 agonists, the anticholinergics, the methylxanthines, when given a short-acting formulation. So SABA, SAMA, and the short-acting methylxanthine theophylline. And then among the controllers, if you give high-dose oral or systemic IV glucocorticoids, they may also be considered as reliever medications. And finally, you can also use short-acting beta-2 agonists oral, no, such as salbutamol. And this is a frequent formulation, typically combined with some cough syrup. We also talked about the controllers, and I emphasize that in asthma, the drug of choice as controllers are the inhaled corticosteroids, the ICS, while in COPD, they're the LABA or the LAMA. But because of a lot of studies already, this LAMA can also be given now in step 4 of asthma in adults and older children, whereas before the LAMAs were purely for COPD. If you give systemic glucocorticoids at low doses, they may be considered also as controller medications, but we do not encourage that a lot, because what we really want is for patients to use inhaled glucocorticoids. The problem really though is the cost, no? While the per day cost is turns out to be cheap, when you buy the inhaler, it will be a few hundreds of pesos, no? And that's why it's a little bit hard financially, no, to sustain asthma therapy for some patients. And so we have also the other controllers, the LTRAs. We have the long-acting methylxanthine doxophilin, or the long-acting theophylline SR. We talked about the chromones. We talked about the biologics and the slit therapy. And this is everything that we've talked about so far. In your clinical rotations later on, you will realize that in fact there are now many combination inhalers, no, that combine SABA and SAMA, for example, or that combine the LABA and the ICS. And please take note that nowadays the preferred combination of the LABA and ICS, so this is the preferred controller, and then it's combined with the preferred bronchodilator. The preferred actually combination for this is the formoterol plus budesonide combination, the so-called SMART strategy. So I will go into that a little bit later. Also for COPD, we now find also combinations of LABA and LAMA. Again, please do not memorize this slide. I'm just pointing out to you that while we have talked about specific drug classes and we talked about examples and prototypes for drug class, what is happening now is that if efficacy is not found with just one of these drugs, it is very useful to combine them. And typically, they're combined in one inhaler. And so just to give you an idea of how we use these drugs in asthma, we will go into the so-called GINA guidelines. I will not talk about this in length. You will have a separate lecture on this. But all I want to show you is that when you find someone with very mild asthma, intermittent asthma, typically they're just given, and you're an adult or adolescent, 12 years old and above, the preferred therapy now is a combination of the low dose ICS plus formoterol. Again, please remember that formoterol is a LABA that has a fast or rapid onset of action. And therefore, giving the ICS will, even in this very mild asthma, will control exacerbations, but can also relieve, as needed, any exacerbations as it happens. And so the greater majority of patients will be maintained on daily rather than as needed low-dose ICS plus LABA combination. And as the asthma worsens, no, then you just step up the therapy from low dose to medium dose and add on other drugs like LAMA, tiotropium, or LTRA, Montelukast, or even for allergic asthma, add on slit therapy. And for very severe, you can add on the biologics. And the same is true also here again, what I had said, the preferred combination now is the ICS plus formoterol combination. And because you will, in one inhaler, have both a reliever and controller. So here, I just want to introduce also in children, it's much the same, no? Except that here, please take note that instead of a combination right away for mild asthma, the preferred in younger children is actually just inhaled glucocorticoids, and it is in higher, more severe stages where the combination is given. So I will spend some time just talking about the so-called MART, no, or SMART strategy. SMART because it's a single inhaler maintenance and relief therapy strategy. Meaning, there are many combinations of LABA and ICS. But if you choose the particular combination of formoterol and budesonide, then you can use this both as rescue and maintenance. So budesonide is the inhaled glucocorticoid, formoterol is the LABA, so they're both controllers. However, once you have an exacerbation, once you have an asthmatic attack, you will not require a separate inhaler to relieve you of your symptoms of your dyspnea. because formoterol by itself, being a rapid or fast-acting LABA, can be used to address the exacerbation. And this has been shown to result in reductions in exacerbation and improvement in asthma control in adults and adolescents, even at relatively low doses of treatment. So that's the advantage of this combination rather than the other combinations. And so once again, I just want to highlight that when you read the guideline, you will encounter many tables like this that tells you what is the dose that is considered of the ICS that is considered to be low, medium, or high dose. And so please don't memorize them. You can just always refer to the tables and you map out where the patient is at, what step, and then you just decide whether to give low dose for those who have mild asthma, medium dose for many patients, and high dose for those with more severe asthma, whether for adults and adolescents or children. That has a different table of suggested doses, and even for much younger children, where in fact what is encouraged is only low dose ICS as much as possible. The inhaled glucocorticoids, while the systemic absorption is minimized, if you give high dose glucocorticoids, inhaled glucocorticoids, could potentially affect growth in children. This is a small but usually temporary effect on growth. And what they have seen is that the effect of the ICS or the inhaled corticosteroids on growth velocity is seen in pre-pubertal children during the first 1 to 2 years of therapy. This is neither progressive nor cumulative and can be reversed by withdrawal of the drugs. And one study even examined the long-term outcomes, where it was shown that the difference is around 0.7% in the adult height. So while administering the ICS could potentially lead to a much smaller or can lead to the child not achieving the predicted adult height, that diminution is actually quite small. And actually, poorly controlled asthma by itself affects adult height. And so giving the inhaled glucocorticoids actually presents advantages, no? In that controlling the asthma will improve quality of life and prevent morbidity and mortality, with some effect on the height. And so it's recommended to check the height at least yearly because of these particular problems. So in the last 3 video lectures, including this one, we have been able to talk about drug therapy for asthma and COPD. We've been able to talk about both the reliever and controller medications. I did not really talk about so much, no, the use of the different types of inhalational therapies. When you go to Therapeutics 202, we will have an activity, a skills activity there, where you will try to learn about using various types of inhalers and even nebulizers. And the reason why you need to study this is because the delivery, the efficient and effective delivery of inhalational therapy will depend on your skill in using the inhaler. And that will depend on the breathing patterns and the coordination between the actuation and the breathing. And by using the inhaler correctly, you will be able to achieve the deposition of the correct particle size in the lungs, no? And therefore, in children, we also need to teach them how to use the spacers so that they're able to coordinate better the inhalation and their breathing mechanics. So it needed 3 different slide sets, no, just to talk about the drugs that are used for bronchospastic condition. And so, with such an array of pharmacologic weapons, there's no reason for an asthmatic to suffer or even die from the disease. And there's more because I need to talk a little bit about COPD, and that will be in the next lecture set. And so I hope that you will finish this set of 4 lectures. And this is the end for this lecture 3 on the drugs used for asthma and COPD. Thank you very much.